DEC orientation. And everybody knows me, don't you?
Mm-hmm. Is there supposed to be a light on?
It's the same. I'm Rebecca Sander. I'm the coordinator here at Hayes Medical Center, and I've been asked to do this orientation today. So you have a handout, and I put together just a little PowerPoint that has the objectives from the proposal that was submitted to the boards on what you're supposed to be taught today. So we're gonna follow that outline a little bit and do some discussion and just getting oriented to the program. So first of all, there's our objectives. We're going to discuss the clinical instructor role. That's going to be a different hat to wear at you're the clinical nursing instructor now. It'll be interesting to be in those shoes. Fun, it's fun, but it's probably different because you're used to being a preceptor or a coach or something like that. And this time you have the instructor hat on, and Siobhan is overseeing that on Skype or by phone or whatever. And we're going to review the adult learning styles because you're going to be working with adults. We're going to discuss how to manage some difficult situations in the clinical learning environment. And then we're going to end with how to complete the clinical forms, including the clinical evaluation tool, which is a pretty important piece. It's that, as you know, it's part of their grade, their performance. So you're playing a really key role in their success. So I didn't know if you were familiar with this program.
They were just asking me about it. I said, well, we will certainly go through that.
The Western Kansas Clinical Collaborative Clinical Model. That is a mouthful. It's a WKCC for short because that's too big of a mouthful of a word. It is an innovative model that addresses the shortage of clinical experiences for nursing students. That's how it came to be. Nationwide, everywhere, there's a shortage of clinical places for nursing students to go to. So we're starting to have to think outside the box. And one of a common option available in the larger hospitals was they had a dedicated unit, a DEU. It was a dedicated unit, and that was nurses that volunteered to take nursing students with them all the time. That was the unit everybody went to as part of this problem of trying to find good experiences for nursing students. Well, we can't do that here. Hayes Medical Center couldn't dedicate a unit to do that, so they put their heads together and came up with, why don't we pick a clinical staff nurse and be the dedicated nurse educator. And they tried that. So they put together a proposal to the state board, and they presented it 2 years ago.
2 years ago they started it.
Yeah.
We've done it 3 times. It's also to get students in more rural areas too.
That's true.
To get them, like we're using Waukene and Colby and Oakley and Beloit and Hoisington and Lyons. I hope I mentioned everybody, but so there's no way you could take the whole class of students to those facilities and they get to see a more rural aspect of nursing care also.
That's true, because you can't put 10 nursing students in those small hospitals. Maybe they tried that in your program in Fort Hays. Tried that you can't put 8 or 9 or 10 students in those little hospitals. There's just not enough to do, and so that was causing an issue too, and it was robbing nursing students of good clinical experiences. And what a waste, because you can learn in any hospital you're at. So they came together, and it's a pilot. It's a 4-year or 5-year pilot.
4-year pilot.
4-year pilot, and at the end of the 4 years, the board's going to review that. And so far, they've gotten favorable feedback. So maybe it might be something permanent, because they're really everywhere's having trouble placing students, because we don't have enough faculty either. There's a nursing faculty shortage too. And also, you can't utilize a nursing faculty member for 1 or 2 students. That's not a good utilization of resources too. So I think it's going to be a win-win. I think that it just may come out to be a permanent thing, not just a pilot. So there's 1 staff member for 2 nursing students. The nursing students are going to work directly with the staff nurse for the clinical experiences. So this is not an observation. They are not supposed to be observing you, and they're actually supposed to be learning nursing tasks, because you are the teacher and they are the student now. Without the instructor in the hospital, in the walls, now they're readily available by Skype or phone, but they're just not there. So those days where you waited for the nursing instructor to come, those days I think are going to be gone. I just don't think that they weren't allowed to do anything without a nursing instructor there. And then you kind of learn that they're in the building somewhere and they're busy, so I'll go ahead and maybe do it. Or maybe the nursing instructor tells you to wait, so and so can do such and such experience. Well, I think those days are not going to be much longer, because there's just so few nursing instructors, and you just can't handle 10 students and still have them learn. They're missing too much experiences. So this is another good way to address the problems and issues on the floor. The nursing students work with one staff during a clinical day, providing all aspects of care assigned for the group of patients. And then the faculty member serves as a mentor or a coach for the DEC. So they're always there when you have an issue or a problem. And as Siobhan said earlier, ideally it's 4-patient team. You have 4 patients assigned to you and 2 students and yourself. So that's enough to have 4 patients, but I guess they can't promise that. I know it might go up to 6.
Other facilities, you never know what they're going to have. You're also
That's
going
true.
to get admissions and discharges, and the students should interact with those aspects of the care also.
So the bottom line is always patient safety. So on top of that, then you all have to just decide yourself how you're going to juggle the day if you're happening to get more than the ideal 4, because the 4 is doable. It's quite manageable and doable because you've got 2 students under you and you're watching, how they're doing and making sure that they're going to be safe and comfortable. And if you get admissions or you get 6 assigned today because it's a weekend and there was issues and that's just the way it's going to be, you're going to have to decide then how you're going to juggle the cares. But we don't want them just standing around watching. That's really kind of not what the meaning about this program is all about. So, what is the role of a clinical instructor? I went out there and Googled that, and there's not a black and white job role. So I kind of just pulled from various resources. They are an expert clinician, leader, and educator. They support a learning environment that's helping nursing students establish some strategies when delivering safe nursing care. They're assuring quality and safety of patients, so that's your number 1 job, is to make sure the patient's safe first. And you're responsible for preparing and mentoring the current and future generations of nurses. And besides being a teacher and a shower and a doer and a master of everything, you're also a very valuable role model. So the experiences they get in nursing school is going to make them or break them. And we really hate to have them have exposures to a lot of negative, everything, negative shift, negative nurse, negative everything, because they're going to get a bad taste of nursing. So we really have to, we're role models and they look up to us, and we have to be sure that we're mentoring very, very good, because they're a positive workforce. The NLN, I went out and saw what they did, and they have broken it down into 3 categories. You're a collaborator and a direct, you're responsible for direct student learning, and you're also a role model. Now that collaborator is a big job. You're just really organizing and collaborating with all the team members, because there's a whole bunch involved every day, and then you have the nursing student on top of that, and families, and physicians, we can go on and on. So the biggest, hardest job, I think, is that collaborator. So what do you think your role is going to be? Are you anxious to try being a nursing instructor? Remember from your nursing school days, you had good instructors, didn't you? And everybody had some, probably a mean one or 2, maybe. Everybody has a bad one and some good one. So you're going to think about what kind do I want to be? What was that good one like, that nursing instructor you had? What they do that you liked? Just throw out some thoughts.
Easily approachable for one.
Approachable is very good. Oh, that's so good.
Knowledgeable.
Knowledgeable, that's excellent. And they can sniff you out right away. I'm sure you did as a nursing student. They know when you know what you know, or you're just kind of faking it. They sniff you out real fast. And if you're knowledgeable, you've got respect already. And you're approachable, they know that you won't yell at them or belittle them or make them feel stupid, that kind of thing. That's a good thing to have.
I know you always want them to feel safe answering or to ask you questions, because I'd rather them ask me than do it and mess it up.
Right.
Be patient.
You have to be patient. Really have patience. So if you kind of know, you don't know yet, you will be tested. Or if you do know you're a little short, you really have to be careful. And there's many times I had to bite my tongue before I opened up the mouth, because right away something came out that you really didn't mean. It just came out because you're just so frustrated, or you just can't believe, or you just shake. It's like, why did you do that? You have to be very patient. Keep that positive attitude and smile on. You've highlighted some really good things. Teach them what they don't know. You're going to have 2nd semester ADMs. Right. They're going to be graduate.
They're just about to graduate.
And you're going to have 2nd semester BSNs. So that kind of gives you some feel. You'll have 1 of each. Will they do that?
as much as I can work that out. It's an odd number and different students going different places.
So you kind of have a feel of where they're at as far as nursing skills. They should know their basic nursing skills because they've already had that. All of them have in their first semester. It's that second semester that might be a little bit different. Some of them might be more comfortable with IVs and all that stuff, and some of them are still in that learning curve and mode. Time management, I don't know. You'll have to feel them out. That's still a struggle all through nursing school. They're not used to having more than one patient. Now they have it. They'll help you with your team here of 4. Giving medicines, it's going to take them a long time just to get organized and set up. And I'm trying to think of other skills. Maybe they might have done some and they might need some help on others. So you're just going to have to feel them out. You know, the most critical skills we're very concerned about is the stuff that's sterile. Anything that's requires sterility. Be sure that they do it right before they do it on patients so that we don't harm patients. And everything else, you just kind of have to go with the flow. I've even had issues where their mouth was flapping, was not professional. Or they're talking about things that they shouldn't be talking about, in the presence of the patient and families, because they're so new and they're nervous. And when you get nervous, you either break out into sweat hives or you just talk like crazy. So you might have to kind of help them learn that role and how to be professional and when to say something and when to not. So teach them what they don't know. Direct what they are to do. You're basically kind of going to be telling them how the day is going to go. If they need some help getting started, there is no way they're going to be able to do that themselves. Now the one that's the ADN is getting ready to graduate. Maybe they might be ready to do a little bit of that because they're going to be graduating soon. But the second semester, Fort Hayes BSN program person, they probably need a lot of direction on how to get started, and that's probably the hardest challenge for all of them, and how to get started after report.
A lot of the ADNs have already worked as LPNs, so they've worked in a different role, and we need to help them grow into the RN role also.
That's true. That's a good point. They think they know what it's going to be like to be an RN, but when they put those shoes on, they're very shocked. Very shocked. It was a little different than they thought. A little more stressful, a little more responsibility than they thought. So help them understand that role. That's a good point. And help them manage their assigned duties, and you kind of have to remind them throughout the day because they're probably going to be always late and behind. But they need a lot of help with that time management. Make sure their cares that they've delegated that they're supposed to be doing are done, bathing, all the ADLs and that kind of stuff, and help them along there. Evaluate all along. You're evaluating their performance because at the end of the 2 days, the weekend, they evaluate, or
It should be every day with that tool, every day. And I suggest throughout the day to use that tool and be evaluating the student.
Integrate theory to practice. I don't know if you understand what that means. I say that all the time. I'm constantly saying you're integrating theory to practice. They memorize what the textbook says and they bring it to the hospital. And you need to help them correlate that, because if the patient doesn't have all 5 or 6 symptoms of CHF or something, then they don't have that. Because they don't understand that they don't need to have all of them. It could be one or none or some, and pull the lab, help them pull the lab and put it together. Help them pull the medicines and pull it together. That's bridging theory to practice. They memorized it, learned it separately in school. So now we're at the bedside. Help them put it together. They really are going to struggle because they're going to look up all the lab and they're going to call the doctor all the lab results. You don't need to do that. Just pull out what's needed for the diagnosis or the issue or the problem, and same with the meds. And I really encourage you to make sure they know why their patient's taking those medicines. All they know is the name of the drug and it's a hard pill, and they don't know anything more past that. And there's more to nursing than just passing a pill with called Planoxin. They need to evaluate that. And some of those medicines are taken that don't correlate with the diagnosis, and they won't be able to figure that out. So help them process that. There's not enough time in the day to do all this, but you're just kind of skimming enough or evaluating them enough to make sure that they're safe, taking care of the patient. They don't tell the patient the wrong information about their pill or why they're taking it, or they're not evaluating the right piece of information according to the treatment plan because they just don't know. They're not correlating it. So do the best you can, because that's the biggest time crunch I think you probably have with 2 students apiece. And be supportive with the nursing students. I don't think we have an issue, but in the past, we have. Nursing students got blamed for everything, and it didn't matter. They weren't even in the room. They got blamed for everything, and so that was a role of a faculty member, is to support and stand up for the student. Now, if they were responsible, we take onus for that. But if they weren't responsible, then you have to speak up and let other staff members know that don't blame the student for that. It could have been someone else. I mean, you really have to stick up for them because they do pay for everything. And provide feedback, and we'll have some little tools here, just a little bit on how do you provide feedback. You want to be positive, and you don't want them, you don't want them to feel stupid or dumb or start crying or whatever. But if they did something that could have potentially harmed the patient, they need to know. And it takes a little bit of practice to give them that feedback because that's negative. I don't know, has anybody been yelled at by your instructor? Hopefully not. You've never seen that on the floor anywhere in your clinical. Good. I'm glad to hear that because it didn't used to be that way. And, tell them what they did great, and then we have to process what didn't happen right, and let them know if they potentially harmed the patient. They need to know that so they'll never do it again. If you don't share that part with them, then they may do it again because it wasn't emphasized, how potential it could have been. Sometimes they just don't understand. When you drop insulin in a TB syringe, they don't get it. And if you don't tell them, you realize if you could have given X number amount of regular insulin, the patient could have died. If you don't carry that out, you just tell them, no, we're supposed to be using this insulin syringe, and stop there. In a bind, the next time they can't find an insulin syringe, they may use the TB again. So it's just part of the process, and it sounds kind of harsh and cruel, and you don't mean for them to cry, but they really need to know so that they will never do it again. And of course, I already said it is not an observational experience. Okay, I have an excellent article. It's one of my favorite, and nursing students were studied. This is a research article, and they came up and they outlined what a good clinical educator was, and I've used this as my Bible all my years of having students on the floor because I wanted to know how to be good. I want to be good. You guys want to be good. I practiced everything that is on these slides. First of all, good knowledge of the facility and a good knowledge of theory and clinical competencies, which that's you are. Knowledge of the students, so it's kind of nice to know just a little bit about them. And we're already identifying what program they're from and what level they are, and that will be helpful so you kind of can, put them in your mind, kind of put yourself where you think they're going to be. Positive, they like being not intimidating, don't make them feel dumb. Be approachable, you already said that. Respected by other professionals, they see that on the floor. And if you're respected by the docs and your colleagues and your coworkers, they will do it too. And a good role model, they want to be like you. They think you're, just know everything and so smart. Have good organizational skills because you've got to pass that on to them. Be the primary resource. So you want them, as you have already alluded, you want them to ask you any question they have. Don't go do it because they're embarrassed. They think you're going to belittle them, or you think you're going to think they're stupid, or they haven't done that procedure before and they're not going to let you know. They're going to go ahead and just kind of do it anyway because they saw somebody do it. We don't want that kind of behavior. They have to be comfortable to say, I don't know how to do that, and you want that feedback back from them. The timely and constructive feedback is very important. In the room, there's an art and a science to that too. If they get started okay, but you're in the room and the family's in there and everybody's watching, and all of a sudden you notice that it's not going to go okay and you've got to stop them. To avoid embarrassment, and we don't want the patients and the families to get a little grip that there's something going on. I've used the kind of body language too before, facial expressions, just the eyes, so that we stop them before they do something without saying anything, oh my gosh, or even in the room, and you've lost it. The patients and families are freaking, and of course they're just like that. But there could be times when you're going to have to stop them in the room, and either you finish it or you take it over, or ask them to go outside. You can make some little reason up why you have to go outside again in the room, if you can. And then go out there and correct it. Give them instant feedback as soon as you can. If they're going to do a sterile procedure of any kind, I always took in an extra Foley catheter in your pocket, or sterile gloves or something, because that could happen. Sterile gloves particularly. Foley's absolutely not. They contaminated it. They're done, and they're like this. They're done. Go ahead and do it for them, because family and patients are in there, and then you can talk about it afterwards, or process it afterwards, or review the procedure in their mind and with them before they walk in the room, because make sure everybody's on the same page and they're comfortable. If they've never done it before, then you've got some things to think about. What do you think your options would be if they're telling you they really haven't done this before?
Offer to do it for them the first time.
Okay, that's a good idea. That's a good idea. Have them watch you. And
Have them run through it before.
You could. And it depends on how much time you have. If they've never put a Foley catheter in a real person yet, but they've done it in the labs, You know, it's gonna take a little more time, so you're gonna have to decide. If it's a stat, hurry up, get it in and out, because the doctors and everybody's, you might have to choose to go ahead if it's their very first time. Same with IV starts, you know, they want to jump on those IV starts, but it kind of depends on the scenario and the situation. And you've not seen them skill level, you've not seen them yet. After you've worked with them, then you'll know what their skill level is and how good, you know, this shaking, we got to get rid of that, because families and patients see that too, and that's going to make you nervous. But they do deserve it, you know, everybody deserves a try or an opportunity, or you can have that rule, well, I'll let you try, and if you don't get it the first time, then I'll go ahead. NG tubes, you know, they're going to jump on NG tube insertion, so it's kinds of things, they're probably going to jump on that to do that. And outside the dummy, they haven't really done it for on a person, so it's your call. If you know it's going to be a hard stick, if you know there's only one vein left and that's it, don't have them practice on that. If you know their NG insertion might not be smooth, they've had trauma, deviated septum, you know, or something like that, they had a history where you suspect it's not going to be a smooth insertion, and just explain to them why, because then they're going to feel like, you know, well, you're not going to let me do anything. I don't, you know, they're going to ask Siobhan for another nurse because you don't let me do anything. You please explain to them why, and I think they'd understand. But then also don't let them back out of everything. You know, we have those people that are, you just kind of got to push them to do it, and they'll use that as an excuse every time. Now, there are times you're just going to have to push them to do it. And here, well, let's go in together. I'll go with you. I'll help you if something doesn't go right. You know, I'll help you. I'll be there, and maybe just get them to go. Get them going. If you have really upset families, you make a good judgment call on that. If you smell risk management case, don't go with your brand new nervous, shaky student. Just go ahead and smooth things over. So it's all your call, because we want families and patients, you know, to be upset either with the care. Do they have the right to refuse a student?
Most definitely.
Yes. In a teaching hospital, they don't. And I'm used to having students in a teaching hospital, because it very clearly says in their admission that this is a teaching hospital. They don't have the right really to, but we usually, you know, evaluated the situation, the scenario, and why make things worse? It's already escalating, so we would just, you know, just help them understand next time, we'll get you next time or something. Question them. Question them. Why are we doing this? Why did the doctor order this? Why is the lab like this? Why are they that? That's the best way to learn. Quick and easy. Why? And if they don't know why, then they're going to have to go find it out and figure it out. And sometimes you can wait on that. Sometimes you can't wait on that. If they don't know any other medicines, what are you going to do? Time to give them.
You can go ahead and give them, but then they have to look them up afterward or something.
Yeah, and that's a choice. Now, give it together, you mean now.
Mm-hmm.
But they're still accountable and responsible for knowing what they just gave their patients, because you have to go in and evaluate and do all that other the rest of the assessment, the rest of the shifts. And they can't go the whole day without knowing why they gave those medicines. And they'll take some time out, so they'll have to go somewhere and do that. If they don't know their labs, I'd be on their cases. They don't know their diagnoses. Really, they don't understand their diagnoses. Give them 5 or 10 to sit down and understand it, or maybe help them understand it very simply, so they understand the treatment plan. Because otherwise, they won't understand why we're doing anything. So that's the best way to learn. They'll love you for it, actually. You know, the pre-conferences. I don't know if you have that beauty to, after report, what do you do? Or is it before
I have
report?
pre-conference before we go to report.
Okay. You do with them.
I do with the students I take to the floor when I have my group.
But this setup's a little different. You're all showing up at the same time on Saturdays and Sundays, right? For a report. So they don't know ahead of time. They can't come in early to do their, and that's going to cause anxiety probably for the junior 2 BSNers. Maybe the ASN students that are ready to graduate, that won't be so anxiety provoking, but it will for the junior 2s, because you know, you're so used to having time, you know, to look stuff up and come and you know the answers. They're not going to know the answers after report. They're going to have this blank look on their face, I'm sure, after report. And you might have to go over it again with them, you know, feel them out and see. You have to do that. So you can't
they may
really
use
test them.
abbreviations in report that the student has no idea what they are, but they feel like they should, so they may be afraid to ask. So remember, when you guys were students, what were you afraid to ask? What do you want to tell them so that they don't have to be afraid that they'll look stupid?
Yeah. I think that's their biggest fear. They don't want to look stupid. They don't want you to think they're stupid. They're so scared of that. So you'll have to kind of figure that out, because you got 8, 9 o'clock meds and, you know, assessments. I mean, you've got a lot to do between report and that first round and your mid round. How you're going to decide how much they know and they don't know. You're going to have to feel them out just from your, maybe giving back the report, you can feel them out on these 4 patients you have, make sure that they have a good handle at least on the disease, or why they're here, or what's going on, or, you know, what the objective for the day is, or something. Make sure they know something. They're not there either to just to follow you around. Maybe that's their concept, and they're
They don't
they're gonna
belong
be-
in this program if that's their concept.
Are you going to have a busy, busy day, which you always do on weekends? And, you know, they don't know, they have no clue what your day's going to be like, so help them when you process that. And, you know, if you really feel like they need some time, then you'll just have to have them park somewhere with the books, and, you know, give them a little bit of time, then they can come in and maybe, you know, sometime during your morning process early, you can have them catch up with you or something. The post-conferences, they will have post-conferences.
That's up to the
Okay.
nurses at each facility,
Okay.
how they want to do that.
If you do want to rope them together, get together, it could be in the afternoon. It doesn't have to be after report at 7 p.m. It doesn't have to be then. It can be in the afternoon if you have some downtime, just to have a little conference. You'll get them together. They want structured post-conferences. Don't just have them sit down and everybody's just sitting there looking at each other and they're waiting for the instructor to do something or say something. I remember those post-conferences, and I still remember what a waste of time they were. We didn't want to go to them. We would punt them. We would make excuses for not going, and you know, it was a waste. It's a very valuable time. And I have a slide to give you some ideas on what to do during those post-conferences, especially if you have downtime or you want to get together after report. If you just had a horrible shift, you're recognizing that you need to debrief them before they go home. Call them in, sit them down, and there's some fun things you can do. I wanted post-conferences to be a learning task, not a dreaded, nothing to do with boring kind of attitude task. And then exhibit fairness, and they will push your buttons on that one. You really do have to be very careful that you're the same with everybody, even though they're all different levels of functioning. You still have to be at the fair level of evaluating, correcting, giving them this, giving them that. You know, they'll see that. It's not favoritism because you have one that's pretty sharp and is ready for all the, and wants to do, and then you have this one over here. You have to take more time and push them. You know, they're going to see that, well, you like Sally better, and you gave her everything, and I didn't have anything today. And you know when that comes out on your evaluation at the end of the day. You know, they don't tell you during the daytime that they really didn't think that was very fair, what you were doing. They'll let you know at the end of the day, which is kind of unfair to them. So that's hard to be very fair.
A lot of times the students will work together too, and one student will say, I've started 15 IVs, would you like to do this? So that helps.
I
The
bet it
different
does.
schools really collaborate, and the different students.
That's good. I'm just giving you the worst example so that you do know what to do when you do get there. Because your one resource is available, but today we're trying to give you some heads up, idea when stuff happens. And then be visible and surrounding each other more. Now that's more for a nursing faculty member that has them all over the hospital, or on 2 or 3 floors. That's what the students are saying, be there. You won't have that issue. You're going to be with them together on the same floor. Here was my ideas for post-conferences. Sometimes you might have to debrief. You had a terrible shift. You had all kinds of things happening. If you had codes and you had just fun little stuff. And because you can't take time out on the floor where you're busy to process and stuff during the 12-hour shifts, to do it afterwards, or that afternoon, a little downtime. If you have some downtime, do it then. Or reflective practice of patient care events. Reflective practices that go back and relive what just happened. And a teachable moment, I've heard the students say that. This is a teachable moment. Well, not always on the floor. Can you stop and go in slow motion and explain what's going on if you have a patient crashing at the bedside? And you can't do it then. You might be able to do it afterwards, after that event happened and they went to ICU or somewhere, or they expired or had a code or something. Or wait till the post-conference and let everybody learn from it. That's the best way to learn, is to replay some really cool things on the floor. They learn from that. They really do. They really rub it in. The farm review, I used to do farm reviews and lab reviews, so they'd go around the room and somebody would say a lab, and the next person would have to give the normal value. Did you do that with me? Did I ever have you play? Oh. Mm-hmm. That's fun. You go around the room like that with labs, and that's a good way to learn labs because they're going to hear it. Don't let them rely on the lab sheets for the basic, the basic stuff, even at CDC, because then they're going to not know it when they get out of school. And they have to be accountable for lab on the NCLEX exam and when they get out for the residency program too. They have to know the basics, the CBC stuff. So that was fun. Same thing with the drugs, have them go around the room and learn their drugs. Or if I had somebody that had a patient that had 4 pages of MARS of drugs, I had them do the post-conference, and they put the drugs on a board, and everybody played a little game on, how to, what they are. So they do learn that way. Concept mapping is great. Everybody knows how to do concept mapping, sort of, but it's a great way to learn the disease process if you're recognizing that they're all pretty deficit. Or any patho-disease review, and if you don't have time on the floor to do that in depth, then bring it up in post-conference. They memorized patho. They didn't understand it, so now that they see it live on a real person and they see all the stuff that surrounds it, it's a great opportunity to review that path again in patho, and I think they will understand it in that way. And then prioritization exercises. They're so cute. They still do the first thing the doctor ordered in order all the way down the list to the last. Why wouldn't you if nobody taught you any different? So do any kind of prioritization exercise that you can think of, because they don't know how to prioritize. Even when you get bogged down with having to redo your day, or you've got these stat orders and there's 5, ask them what would you do first on this stat order that has 5 or 6 things. They just don't know where to start. So all those are beautiful, valuable teaching methods you can use on the floor. Any questions about being that good teacher? I think we have good teachers in here, Shawn.
I think so too. I've
Okay.
known them all for a while.
The characteristics of an adult learner, we're just going to review this because it is an objective of orientation. We're all adults, and these nursing students are over 18, so they're considered adults. And sometimes we have older learners, and sometimes we have that 18 to 22 age. But they're all autonomous and self-directed. So you kind of you involve them, and you serve as a facilitator, and you kind of determine their interests. But what you're doing is kind of feeling them out at the beginning of the day, kind of deciding, what all they wanted to do today. Determine their interests. They have a foundation of life experiences and knowledge, so we do recognize the expertise. If you've had PCTs, like Siobhan's saying, LPNs or PCTs, we do acknowledge that and use it if we can. The skills that they already came in with. Be cautious though. Sometimes they're showing some unsafe shortcuts. You never know. From clinical practices, what they've been shown that maybe aren't really the way we do it in your facility or are unsafe. They can decide when they're out of school with their own license if they want to do those, but while they're in nursing school, and you all know yourself when you're a staff nurse, you really have to go back to doing it the way you're supposed to do it. In nursing school, we want them to learn that first, and then they make their own choices later on the shortcuts that you all learn later to survive the shift. And they're goal-oriented, so be organized and have clear objectives. And I'm hoping the objectives are very clear for these experiences. It sounds like these weekend experiences with you, they're very clear. They're relevancy-oriented, so explain how the clinical objectives relate to the assigned clinical activities. So it's helpful to have the objectives for this clinical rotation. It's helpful to have the evaluation tool. Do they have it too ahead of time? Everybody should look at the evaluation tool.
Mhm.
So everybody's clear and you're on the same page.
I send the evaluation tool to all the
Good.
supervisors
Okay,
and
good.
all of the students, so everyone should have it ahead of time.
That's one thing that's never done. They show up. They don't know why they're here today. No, they don't read their objectives. And nobody looks at the evaluation, so you really don't know what you're supposed to be evaluating until you're all done and students are frantically filling out their tools and faculty are doing their tools. That should have been done on the first day, so everybody knows what page you're on. They're practical, so the relevance of the need to know for patient care. And that's why you're asking the why. You're asking them the why are you doing this. It's how come they have to know that. That's all about the relevance of patient care. And they need to be respected. And we treat participants as equal rather than subordinates, and that is, I think it's getting much, much better. Everybody should respect, and we should be very respectful when we're giving positive and negative feedback. We should be respectful of even the mid errors they make, because we all will make mid errors. We all make mid errors. We all have potential to make mid errors, and of course, when they make them, they're crying. They're in the bathroom. It's the end of the world. They're gonna get kicked out. They're just devastated. And, we just have to kind of respectfully handle that. It just happens to all of us. So here's 5 good key principles for effective adult learning is respect and immediacy, engagement, safety, and relevancy. And I think we kind of highlighted and just mentioned all those already. They need to be accountable for their own learning now. You know what's the hardest thing to as a teacher is to go look it up for them, to go tell them what that medicine is out of your mouth, instead of telling them, why don't you go look that up and we'll come back, you know, do something else. It's just so easy like that because it takes time. It's going to take time. And they just tell them this. They tell them this. And that's the one thing I saw as a nursing instructor all those years as a faculty, and they were just being helpful. I mean, the staff nurses, and they were being helpful and kind and nice, and it's quicker, and I understand that. They just thought for them. They told them, didn't go make them look it up. So they're accountable for their own learning. So if they really didn't do that in their skills lab, some scenario like that, well, that's it for the day. They need to go practice that somewhere, and then when they come back the next weekend for the next shifts, then you can let them do that. But if they've never done that skill in the lab, let's say, it's not your fault. That is their fault. So I wouldn't begin to even think about showing them how to do a Foley catheterization on a patient if they've never had it in their lab, or an NG tube if they've never had it in their lab. You know, and it comes up, you know how they, enemas, you know, something like that. They've never done a bed bath yet because their CNA and their CNA classes, you know, they just took it for their CNA and never had any practice behind that. If they're telling you they don't know how to do a bed bath, you know what, I wouldn't take the time out to show them that on your time, unless you want to, unless you have all this downtime. You know, they're accountable for knowing that stuff, so send them somewhere to get practice and they can come back. So make them accountable. Need to see how learning can be done right away. They hate to waste time. Everybody hates to waste time. They shouldn't have any downtime either. There's plenty of stuff to learn from chart reading or from looking stuff up. There should be no reason for them sitting around. There should be no downtime for them. And they need to feel welcome and comfortable, and I don't think we've had any issues with that. It sounds like this program is doing a great job. Need to have trust in learning that's being delivered, and I think that's no issue. They do not want to be judged. They want to be recognized or affirmed. And that's just adults. All adults want that. Other key points to keep in mind is the targeted feedback. They just have to have feedback and targeted feedback. Not the vague quotes like, I don't know, that wasn't done very well. I mean, that's so vague. Or maybe you should do that again. Give them specifics. Give them very specific. It helps their learning. And reinforce positive and negative. And be careful. We can help assist their skills, but we can't change behaviors. So that's real hard. If you have a complaint about your student and it's a personality thing, you know, I don't know how you can address that. I don't know how you can fix your student. It's a personality thing. You might be able to kindly address if it's obnoxiousness or if it's, I don't know, inappropriate conversation, or I don't know, you can maybe kind of address that while they're here in the hospital, but you can't change personalities. It's really hard to do that. Right, Naomi? Have you ever had that? Has anybody ever had that where you just wanted to?
Yeah. We all have to work with difficult people, and we all have to learn how to deal with that.
Yeah, we can't guarantee you perfect students. I mean, there'll be some that just kind of, they'll upset the family or the patient. I mean, something kind of will happen, and we just really can't change behaviors, but we can try to change the skill level.
There have been times if there was a really serious problem, I've had to come, and we've put the student with another nurse, or there was a time that I took the student for the whole day. We may have to move them to a different facility if it's the outlying facilities. If it simply does not work, I need to know, and we need to find a way to work through that. That's one of the things I'm there for, is to help you work through
Please
those
do.
conflicts.
Don't torture yourself. Don't compromise patient or family issues, you know, in your hospital. Get Siobhan on it right away, and maybe it just has to be that way. It does happen. You know, patients have fired students.
Patients have fired nurses.
Yeah. You go in and you have to kind of, you know, do a damage control and probably that student can't have it. I've called and said I can no longer take this student. They're unprepared and they're unsafe. I've done that, and I've told that faculty member, I'm not taking this student anymore. We're done. You know, not that it wasn't that rude to the student, but it was that firm to the faculty member. And of course, you have your detailed reasons why, and anytime they compromise patient safety or that they're making you very uncomfortable, you need to do something, say something. Just don't do your time or don't torture yourself all day. Do something. There's options. There's things we can do. Okay. Learners need to monitor and adjust their approaches to learning. They're responsible for their own self-learning too. And retention. It's directly affected by the amount of practice during learning is their retention. So how much they remember is how much they practice. That's just a common adult key there. Okay, I don't know how to help you with feedback. I'm sure probably you've had some exposure and experiences with students anyway where you're working, but feedback is open and it's honest and it's timely and it's two-way. And it increases the performance, and the feedback provides motivation for their continuing improvement. Surprisingly, my generation does not like feedback because we weren't raised that way. This younger generation, they want it. They keep coming up and saying, how am I doing? How am I doing? Am I doing okay? And that's just so strange because the faculty members are from the older generation and we didn't get that. And they want to know. Most of them want to know. Or maybe they can tell they're not doing well, or maybe they can tell they are doing well. So I appreciate that they want to know. I like that when they come to me and say, how am I doing? Instead of waiting till the end of the day and then we have a uncomfortable conversation at that time, or they're just finding out at the very end all this stuff happened and no one told them, or somebody complained about them, or the family, they didn't know that to the very end, which is kind of unfair to the student too, that they didn't know all this was going on behind their back. They want to know, and we try to correct it as fast as we can. So it's not to blame or criticize, it's just to help them improve their performance. So you can open it up with that kind of verbiage to help a little bit. I don't know how much they're used to getting direct feedback like that, because see, they're not used to having this 2-to-1 ratio. They're used to having the instructor with 9 other students, and and they're just not used to this so close. You guys are very close to them as far as giving, exchanging feedback back and forth. They're not used to that, so we'll feel them out and see how it's going to go. It's probably all related to personalities. Some of them may like it, and some of them may not.
Some of these students in the ADM programs may have decided to go back to school when they're 40. So they may be of Becky's generation and not want the feedback.
Oh. Yeah, that's true.
So you're going to have all kinds of different
It's hard to give them feedback.
perspectives and attitudes.
Yeah.
But it's necessary for learning.
Yep. Evaluations were dreaded. They were dreaded. They were punitive. They were mean, ugly, and nasty. My generation was. Now they're linked to your job description. It's all black and white. It's very clear. If you don't cut the mustard, this is what happens. So it's much better than it was with the older generation. So be careful if you have an older student coming back and getting their degree. So you get to do both. Everybody dreads the old evaluation. It is hard to evaluate. It really is. You're so afraid of controversy, conflict, getting sued. Oh my gosh. So you don't want to say anything. And it has to be black and white. Your evaluations have to be black and white. They can't have any opinions in there. Versus feedback. So feedback's a little easier to do, but evaluation is grading. So you really have to be very black and white if you're making notes on everybody. And it sounds like Siobhan said the easier way to do it is to evaluate daily on the 2 you have, taking little notes, writing things down. It has to be. Don't say they were late for report. You know what you say? Arrived for report at 7:15. It's really late. So don't say late for report. You put down the time. And did not know the meds action. You just kind of you have somebody going like that all day long. By 11 o'clock, you should have a lot of stuff written down. If you're having a student that's just not doing well, and you got to call Siobhan and tell them.
Students should know this too. That's why you fill out the tool together.
Yeah.
The student and the DEC should really work together to complete that tool. But if there's problems that you can't talk to the student about, or that the student can't talk to you about, I'm there.
I don't want to tell you all the things that I've had done to me. It might scare you to death, but I've had them falsify the vital signs because they realized that they forgot to take them. It was 11 o'clock or whatever. Somebody's asking for them, and they panicked. Or one of them did on purpose, who immediately got withdrawn from the program. But sometimes I've had that happen, and then it got witnessed, And so therefore, they were off the floor immediately. You know, anytime they do anything like that, you know, that's the worst extreme. But there's just been, and you know the days when we had the heparin flushes and we used the sash, and they come to me and they want to do all these IV antibiotics, and okay, and I would look, all I have to do is look at their little tray, and if they didn't have the flushes, you know, the heparins, they just come with the medicine, nothing else. So that clued me, and they didn't have any idea how to give this medicine. So I wouldn't let them. You know, I'd send them back, or they didn't have the right syringes. You didn't have the flush. I mean, you know, all kinds of stuff like that. Kind of gave me little clues that they weren't prepared to do that skill, and I didn't have time to tutor them from beginning to end. So I sent them back, or they missed that opportunity, and then the next time they can try it again, and then they'll learn. So I'm trying to think of some things where. That, you know, they all deserve a second chance, and we can't expect them to know everything when they arrive. They don't have the day before, you know, heads up to prepare. You know, we have to kind of consider that too. We you know, we can't ding them for not being prepared because they couldn't come in, because we don't know until they come and show up what they're going to have today. So you just kind of have to feel that out. But if you're getting the same thing over and over again, that they don't know what they're doing. They don't know what they're talking about. They're just making you nervous, and you know, document and non-judgmental images. Just put the facts down. Don't put any opinions in there. But that's hard to do. You want to put in there just.
Actually, monitoring their documentation is going to be very difficult because they may be inexperienced with the
All the
facility's
time.
documentation systems. So that has been a problem before. It takes time to explain it. They may not have the opportunity to document, or they may have to document for practice until they understand what they're documenting and how the system, whatever system used here, Meditech, however that works. Because some of them may not have even seen it before.
Yeah, that'll be well, you might have to kind of compromise on that part. Who's going to charting? That will bog you down. They've not worked very much with Meditech. That'll bog you down. And you want to make sure that stuff is accurate. You know, the breath sounds. You make sure they know what they're talking about. The breath sounds particularly. I can't tell you how many times they documented the wrong one. The physician read that and did orders accordingly, and then found out they weren't correct. And they're so new, they shouldn't be clicking and saving that without you checking with them or having you listen to make sure to validate, particularly breath sounds. That's probably the biggest issue. I think you kind of tell if somebody's a little weak. You want to make sure that they're going to be okay for the day, and if not, you just have to highlight and document, and maybe at the end of the day have a little plan for them for the next day, and give them some help for hands-on how to be better. So the evaluation is scheduled informal, and it has to be objective, and it's kind of more global, and it is the grade versus feedback, which is timely, right at the scene, right at, quick. It's specific, and it's for improvement. It's informal. And here's the learning domains. You probably heard this in academia: cognitive, affective, and psychomotor. And the cognitive is their thinking, their critical thinking, their thinking. And we do want them to process at the bedside. We want them to start thinking that they need to start learning how to do that. There's 4 levels, and there's 4 different levels of the ways you can ask questions. If knowledge is just, rote regurgitation of memorization, the signs and symptoms is a good example of a knowledge question. What are the signs and symptoms of CHF? Well, they're just regurgitating from the memory book. If you want to make that a little harder, and I would push them and challenge them to start thinking and processing at the bedside. Comprehension. Who will you contact if the patient's urine output is low? They have to think about that, put 2 and 2 together and figure it out. The application and synthesis and evaluations are higher level, and that should be called the doctor. Is excellent question. Excellent question. If there's a process behind that. And please push the S-bar for calls. Everybody got to do the S-bars. That's the best way. Some programs do very well incorporating that in their curriculum, and some kind of just scratch the surface thing. It's really critical with communication when you're calling the doctor. And then that is the TPN accomplishing the goal. Ask them any question. How do you know giving this such and such is helping the patient? That's a beautiful evaluation question. It's a very high level question. You're really going to make them think. They won't know the answer to that. Gaining weight for TPN, I don't know if that's, is that really the right answer? How do we know TPN is working. The affected domain is their attitude and emotional areas, and we just can't evaluate that. We can't evaluate or fix it. That's more personality. And then the psychomotor is their hands-on skills, and you will be evaluating their hands-on skills and giving Siobhan feedback. If we need to do something to fix something, we'll do it before they go touch a patient again. Well, there's that. Did you still want to use the DVD?
If that's okay. I thought it was pretty good.
Let's quickly do the one DVD scenario. And then we'll talk about.
Yeah, I think this just lasts 3 or 4 minutes.
And Sally will be needing to give the client their regular sliding scale insulin. The scenario will start with Sally and I having a discussion in the medication room or at the nurse's station. And in this scenario, the intent is to demonstrate inappropriate or poor teaching practices. Hey Sally. Hey Loretta. So I was just checking the charts really quick because I heard a report that our patient, Mr. Matson, has a blood sugar of 160. So I was just double checking his sliding scale insulin orders. And so based on that blood sugar, how many units of insulin do we need to give him?
We need to give him 2 units of regular.
Okay, good. So I'm just going to double check that with his MAR here. Here's his name, date of birth, same guy, sliding scale insulin. Good. Yep, he gets his 2 units.
Okay.
So have you drawn up regular insulin before?
In the lab, yeah.
Okay. Feel pretty okay with that? You passed your lab test?
I passed the test, yeah.
Okay. Why don't I let you go ahead and draw this up then, and I just need to go check on Kendall, one of my other students, and then why don't I meet you in the room? I do have to double check all insulin before you get it, so just bring the syringe and the vial into the room and we'll double check it in there.
Okay.
All right? So I'll catch up with you in Mr. Matson's room.
Okay.
Thanks.
Mm-hmm.
Hi, Mr. Matson. Hello, I'm Loretta. I'm going to be your nurse today. How are you doing? Doing okay?
Okay.
Good. Can you tell me your name and date of birth?
My name is Clark Matson. I was born August 12, 1951.
Good. Okay. Well, I have my student nurse out drawing your insulin. Oh, look.
Hi.
Here she is. Hi, Sally.
Hi. Hi, Mr. Matson. I'm Sally. I'm the student nurse working
Hello.
with you today. So I have your insulin here. If I could just get you to tell me your name and date of birth.
My name is Clark Matson. I was born August 12, 1951.
Great. Okay. I'm going to give you 2 units of regular insulin, and I'm going to ask Loretta to make sure that's okay.
Okay.
Take a look at that. Thank you. That's right. Well, Sally, there's a problem here. You've made an error.
Oh.
So go ahead.
What do you mean error? What does that mean?
There's been a mistake. It's okay. We're gonna get it fixed and it'll be okay for you. Go ahead and take a look at what you have here. Do you know what's wrong there? There's something wrong with
Does she
your...
really know what she's doing here?
Well, she's learning. She's a student. It's going to be okay. We're going to get it done right for you, and this is pretty normal for students. So there's something wrong with your syringe, Sally. What's wrong with your syringe?
Oh, I think I don't have quite 2 units in here. I might be a little
No.
short.
The problem is that's a TB syringe. It's not an insulin syringe. You have the wrong syringe.
Oh.
So I need you to go
Oh, yeah,
back.
I'm patient here.
I know.
You know.
I know. Tell us, are you feeling dizzy, or is your blood sugar getting to a point where you feel like it's higher than normal?
Okay.
You feel okay? All right. So I need you to go back out to the medication cart and draw it up in an insulin syringe, and then we'll give it to him.
Oh. Okay.
Okay.
Be right back.
All right. Thanks. Sorry about that, Mr. Madsen. I'm going to take care of it.
Stop it.
What do you think of that nursing instructor? What do you think that patient thought of that nursing instructor? And then, of course, there's what the student thought of the nursing instructor. I would never go to that nursing instructor again for help.
Probably should have checked it before they went in the patient's room.
Most definitely.
Yeah, there's mistake number 1.
I don't think I'd let her draw it up by herself, honestly.
Yeah, even forward than that, I would not let her, I wouldn't turn her loose. I would have asked
Yeah.
for some more information about.
Have you ever done this? Well,
No.
only in the lab. The student was saying, I'm uncomfortable.
So then we would do it together, drawing it up.
And a lot of times I'll take 5 different syringes and say, or 5 different needles, which one of these would you use? In where we have the syringes and stuff, away from the patient, never in the patient's room, but give them choices so they have to choose things.
That's how they learn, because you just do everything for them, they'll never, and then they go do it by themselves, they don't know how to do it. So that's the problem, even in the skills lab, we're showing them everything, and then we put them in the hospital, and, you know, if we do everything for them again there too, they'll never learn when they're on their own. She was guessing, and I knew she was gonna grab for that TB syringe, because I would do that
That's
too
what
if
they
I didn't
all
know
do.
exactly what I was doing. She was guessing, so those are good points. What about the way the nurse introduced the patient to herself and then the student? How do you do that? She sort of made it sound like, and I'm watching everything she does today. I mean, she didn't come right out and say that, but the way she introduced herself, it sounded like, and I have a student, and it sounded like I'm watching everything she's doing today. So already off the bat, I would be kind of nervous. I'd be watching them. If I was a patient, I'd be watching everything she did. So how do you introduce? How would you going to introduce your patients with your students when you have them?
I've always gone together. I don't think I've ever actually labeled them as students.
See, thank you, Naomi. Thank you for that. Don't label them. Don't label them. They don't need to know unless they ask, "Are you a nursing student or something?" But I wouldn't label them. They don't need to know. They have a badge on, don't they, or a patch anyway, so they'll probably figure it out. But you go in together and you introduce them together. And this is Susie, and we will be doing your cares today, whatever your entry line is, and don't stick them out.
Although a lot of the students, I think, were taught to identify themselves as students, because when I go into a room with students, they're always saying, "I'm a nursing student, I'm going to be working with you today."
That's
I mean, most of them will do that. I'm saying, so patient, in our case, most of our patients will know they're students, because
Yeah.
I think they were taught to identify themselves as
Yeah.
students.
But I guess I just don't highlight it. If they want to say that, I suppose that's okay, as long as the patient doesn't care. And most of our patients here don't care.
And when they say that, I usually say, instead of making it seem like I'm overseeing them, I'm like, "We're working together today to give you care," or something
Yeah.
like that, so it sounds like we're,
A team.
A team, yeah.
You're a team.
Usually if I go in to see a student, I'll say, I'm Siobhan, I'm the nursing instructor, I'll be in and out.
Mm-hmm.
You guys both let me know if you have questions, if there's anything I can do.
We just don't want them to feel like they're a guinea pig for
Sure.
the day. Because some of them might feel that way. We don't want that to happen. Is there anything else that nursing student? Oh, I guess we could have. I don't think so. As you see them do the procedures and you're really getting comfortable, then it's your call as to whether to go ahead and let them go forth and not have you right there. That will be your decision, especially those second semester ADNs who are ready to graduate. They might, they may not need you attached to the hip all the time. That second semester junior is still so new, they may need you, just for their confidence or to be in there, but maybe the second year may not. So, just don't send them here and there and everywhere, without going. And I've seen nurses do that because of time, and they assume that I think they think that student is pretty good, but you never know that until you see it for yourself. You've got to see it for yourself. Too many people make assumptions that they, send them in for IV stuff, and just because they work in an LPN, it still does not mean that you should turn them loose with IV meds. I still, unless I've seen them and they're very comfortable and they're very sure of themselves, and after you have talked with them before they walk in the room, they know the medicine, and what to watch for and how to give it right or whatever, and then maybe you can send them on. But just to be safe, patient safe.
And of course, there are some students who come across very self-confident, and yes, they know how to do this, and then you walk into the room and see something that's not appropriate or not set up correctly. So be careful about those things too. The overconfidence can get to them also.
Yeah, that's true. That's very true. Well, the second part is I made up a couple of examples, and I'm going to give everybody 2 of them since it's such a small group. And you just read it out loud and tell us what you would do if your student was doing these 2 things. And we'll see if we agree. Because everybody's different, and we all have different personalities in here. You want to start? Read it out loud.
My first one is, your nursing student is not prepared to give IV meds safely. And what I'd probably do is, before we even went in the room, I'd have them verbalize to me what they believe the process should be. And if the process if it was wrong, I'd say, okay, this is the way you do it. Why don't you come in and watch me one time, and then next time we'll talk it over again and see if you're ready.
Good job. I think that would work okay. I don't think that would hurt my feelings. Maybe next time I would be ready. Good. What was your second one?
My second one is, your nursing student is talking too much about personal stories or inappropriate topics in the patient's room. I talk too much in my patient's room.
But we know yours is appropriate.
Yeah. I'd probably interrupt and try to say, okay, well, we're going to see you in a bit. We got some other things we got to take care of real quick. And then we were out of the room. I'd kind of nicely tell her to can it. And them to can it.
How do you say that?
No. With a smile on your face, you say,
she'd be like, and she's cute and everything, but that wasn't quite appropriate to what we were getting ready to do. Or, the story about your baby daddy doesn't really go in with this type of care. Your TMI.
Those are hard. The hardest issue I ever had was telling them that they had their breath was really bad, and the VO. Oh, we had a nursing student. I think she took garlic, supplements, and that's expired in the perspiration. And I had to tell her, the patients were complaining. I had to tell her that she smelled, and it was so hard. She was a very lovely, nice person. Had no idea that she smelled bad enough. Patients started complaining, and I had to tell her. And the bad breath stuff too is really hard to tell people. So I always had a mint. I offered them a mint or a piece of gum or something, and if that didn't work, I'm trying to think. I never did really learn the line.
It is so hard.
To use,
just a couple of weekends ago, I had a friend who's an instructor call me, and she said, one of my students smells of cat urine so bad we can't stand it in the nursing home. And she said, what do I do? I said, well, ask her, does she have a cat? And we talked about all kinds of different things where she could handle it. And it's just hard.
It's hard, and you have to. Especially if you're working with oncology patients too. Any odor, upsets them. And the reeking of perfume when they arrive, the perfume arrives before they do. I've had that scenario too. And you just have to respectfully and professionally, nicely tell them they can't do that. So good luck with those. They do come not very often, but you're going to have to probably, the breath issue could probably be the hardest. It's hard to tell people because it does help. It harms patients when they're
I just keep gum in my pocket.
Mm-hmm.
And they're like, hey, here you go. Yeah.
Yeah, and I've also blamed it on the dry air. You need some, that
You need
kind
to
of
go
thing.
get
The
something to
dry mouth.
drink.
Yeah, you need a drink of water, something like that. Because I said everybody, gets when their mouth gets dry, then we start having, bad breath issues. I say we, not
Or
you.
after lunch. Hey,
Or after lunch, yeah.
No.
They ate a onion or garlic or something,
Did you here's some gum.
And I use the we to try not to make it look like I'm, kind of, and it's such a hard topic to tell somebody that. Okay, the next one.
All right, you are suspecting the vital signs are not accurate or not accurately charted. You don't think the nursing student knows how to run the equipment.
How would you address that?
I think I'd probably, to make sure on that patient if it was correct, I think I'd probably say, we need to get another set of vitals on here. I'll go in there with you just so I can watch them use the equipment to see how that works. And then I can compare it to the vitals in the computer and see if they're close or not.
That's a good
And if they don't know how to use it, then when they get out, I'll say, okay, here's a few things we could do to help you with this. You need to do it. Maybe this way would help you a little bit better. Not that was wrong, but this might be a more efficient way to use the equipment.
That's very good. You'd be nice.
That
You'd
is
be
nice.
That is nice.
Yeah,
Before
the
you
second one's
send
not gonna be
someone
so
to
nice. I
do
haven't-
something like with the vital sign machine or the IV pumps, recognize that there's all kinds of them. Are you familiar with this machine before they ever go
That's why I said,
start?
go in there, see how they use it, just to see.
We're finding
Before I say, you don't know how to use it.
yeah,
I like
and
to see it for my own self.
And I know you're kind of surprised, but it does happen.
Well, I've seen different ones. There's some of them I had to play with a little bit to figure them out. This other
Good
one's not as
job.
nice. I don't know if I could be as nice ones next one. I started with the easy one.
Yeah.
A family member has complained to you about their nursing student and doesn't want them to continue to care for their loved one. I guess I'd first nicely talk with the family member to see is there anything in particular so I can let them know that I want to correct the behavior, but I need to know what they did that made them uncomfortable so I can fix it. And then I could go talk to the student and say, I don't know how to word it, but basically let them know it may not necessarily be them, it could be a personality thing, but these are some things they could do to help. But for right now, we're no longer going to be caring for this patient for their satisfaction. So that's hard. There's no nice way to put it. Your patient doesn't want you.
I know, it's hard.
You've been fired.
Yeah, it's hard and it's devastating, and they're going to start crying maybe because they take it personally, and I would too if all of us would have got fired. Our patient fired us. We take it so personally.
Well, and I
just
had that
feel
situation
bad.
not too long ago. I was talking, and a patient had nothing else going on in the room, so they kind of overheard. They heard me explaining to a student about why they were nauseous. I was trying to explain to them what was going on, and then the doctor walked by, and we were talking about a whole different patient. Well, they thought I was talking about them,
Oh, no.
so they went to my supervisor, and it was someone I knew. That was what made it worse, because they couldn't believe I would do that. So then I went in there, and I go, if you don't want me to be your nurse, that's fine. I go, but can you let me know what I did so I can fix it? And when she said, I apologize, and I go, I am so sorry. You heard two different conversations. She goes, I don't care if you thought I needed a supplement, that was fine. I would take the supplement, but you never talked to me about it, and here you were saying I was refusing it or throwing a fit about it. And I went, or I forgot how she worded it, but I go, no, that was a different patient. I was trying to get a supplement for them. I was talking to the doctor. I'm sorry you overheard that. And then she felt better because we talked it out. But
That's good.
so I know how just communication, they hear things wrong too, can make a difference, because she really didn't think I was talking to two different people.
Wow. I see how easy that can happen. Yeah.
So
I get the patients who, if they try to fire me, I'm like, good. And then they start laughing, and I don't want you to go. I'm like, darn it.
well, yeah, it was just, she knew me, so it really hurt her more because she thought I was talking about her when
Oh,
it wasn't
yeah.
even her. And I was like, no, supplements had to do with somebody else. That was me talking to a doctor. I'm so sorry. But
That's good. You've got some good strategy. That's a hard one.
that was hard.
Just want you to think about it now before it happens on the floor. Okay.
Your nursing